May I request Dr. Srinivas Ramaka? Yes. Sir, kindly introduce our speaker for today. Vivek sir, I request you to kindly introduce our speaker.
No, sir, they haven't.
Anuradha, I think this CV they haven't received. Anyway, let me take the pleasure of introducing Dr. Srinivas Ramaka Srinivas. He's been a distinguished cardiologist working in Warangal.
Slide. Excuse me. Excuse me.
He had a passion for out-of-hospital cardiac arrest and resuscitation. And for such of those who think research is not possible in smaller places, Dr. Srinivas has been an exception, because careful documentation of the case sheets and then kind of going back and revisiting them of 2 decades of data has resulted in the publication which was shared in the first. He has presented his work American Heart Association and has been an invited speaker there, and we would love to Srinivas.
ఇది కూడా చూడు. Good morning, everyone. At the outset, I would like to thank the IMA Telangana State Branch, IMA AIG Branch for giving me this opportunity to speak an important topic. I feel humbled by this recognition on speaking at a place where my mentor is there, Dr. B.S. sir, as we popularly call him, Dr. Somaraju sir. Physically, I may not be able to reach his height, but at least even academically, I am for the last 26 years since I left his team, I have been making a small attempt academically to reach his height. Hopefully, sometime in life, I would reach his height. Thank you. Many of the attendees, when I conduct a lay rescuer CPR program, particularly for NCC cadets and lay public, one of the commandants asked me, "Doctor, why are you leaving your practice and doing these training programs in CPR?" I think I need to answer this. From the time I was a child, from the time I have been a postgraduate in Usmania in the 1990. A few days after I joined my PG in Usmania, in FM2 ward, in an afternoon around 2 o'clock, one of the patients and her attender, they came to the ward and they garlanded me. I was surprised. My house surgeons were taken aback. They asked me. Then I asked the patient attendant. He told, "Sir, when you were in the AMC a week back, where my mother was hospitalized, she had a sudden cardiac arrest in the AMC and you attempted resuscitation. Luckily, she is in front of you now." Okay. In the same hospital, a few months later, we could not revive a patient in the early morning. A patient with septicemic shock, with atrial fibrillation and multiple comorbidities. what I mean to say is, whether we receive brickbats or bouquets in reviving a patient of hospital card, whether it is you or I think Gita says we have to be equanimous, but it is difficult. Subsequently, while facing one of the sudden cardiac arrest, non-survivor in a close relative, a family member, and having seen many out-of-hospital cardiac arrests brought to my clinic during the last 20 years of my clinical practice, and some of them survived, luckily, by God's grace. All these things, probably knowingly or unknowingly, created a lot of interest in the topic of sudden cardiac arrest in general and out-of-hospital cardiac arrest in particular for the last 20 years of my practice. And I continue to work on this topic, both in creating awareness, doing research, and teaching and training lay public in what is called as the ART initiative or the ART program, which I coined. Coming to the topic of out-of-hospital cardiac arrest or sudden cardiac arrest, the reason I chose this topic is to share my work, which I have been doing for the last 20 years as a cardiologist. Basically, I am a non-invasive cardiologist. I had a lot of opportunities, as I told you, to learn interventional cardiology under Dr. Somaraju sir and his team. But being more attached to my hometown, Warangal, I moved 25 years back to the place and started practicing non-invasive cardiology, particularly in a low-resource setting. The main reason why I chose this topic is, apart from sharing my work, to enthuse interest among all the branches of IMA to choose this important topic both in creating awareness, conduct research, and teach and train lay public in this ART initiative, so that the ultimate aim of you and I should be to improve survival outcomes from out-of-hospital cardiac arrest in Telangana in particular and throughout the country in general. Coming to this is my now. Always the reason I am focusing this is, again, what the number of patients whom we see in our crowded clinics or hospitals, the number of patients who are hospitalized, and the number of patients we evaluate and manage is only the tip of the iceberg. So and even this concept, the tip of the iceberg, what I learned in my social and preventive medicine is, we should be able to see that this tip of the iceberg concept is reversed. The outcomes of out-of-hospital cardiac arrest, which is less than 10% throughout the world, should be improved. The number of patients who are suffering from cardiovascular disease and whom we see, we should see that there should be a population screening for cardiovascular disease, and our knowledge of cardiovascular disease is only the tip of the iceberg. There are so many unanswered questions about cardiovascular disease in general and out-of-hospital cardiac arrest in particular. So this tip of the iceberg concept should be reversed. Day in and day out, when we see the news, we have so many instances of out-of-hospital cardiac arrest which are reported, which say that the outcome is very dismal. But is so? Now, of late, we have been hearing, thanks to the efforts of so many people who have been conducting lay rescue CPR programs and the improved survival care, improved care given in the hospitals post-cardiac arrest care, the survival rate is improved, and even the Telangana government has started this. Okay, right. So, in the next few minutes, to improve the survival rate of OHCA in Telangana, in particular, we need to updates of out-of-hospital cardiac arrest, and majority of them have been covered by Dr. Vemuru Murthy garu. Like, what is out-of-hospital cardiac epidemiology? Like, what are the Houston data elements? What is the chain of survival? What is the community interventions which are important in improving the survival of OHCA? Bystander CPR. What is Houston survival? Resuscitation education concepts. High-quality CPR. Strategies to improve AED usage. What are the predictors of survival? Resuscitation systems of care as per international guidelines like AHA, post-cardiac arrest syndrome, role of cardiac cath lab in management of OHCA, prognostication of OHCA, COVID and OHCA, and what is the need to address OHCA in India in general and Telangana in particular? I think there's a problem with the out of hospital cardiac arrest. The loss of functional cardiac mechanical activity associated with an absence of systemic circulation occurring in a hospital outside a hospital setting. Survival rate on average is less than 10% throughout the world. Some countries in an optimized chain of survival, the survival has increased to 20%. But in some settings where they attempted to improve the survival rate, in the best of the settings, the survival OHCA has increased to 50% too. There is variation in reported survival outcomes throughout the world, and the common cause is an acute myocardial infarction. Other causes like cardiomyopathy and other causes are also described. One word about Houston data elements. They are the foundation for clinical research. If you want to do a study on out-of-hospital carriage, Houston data elements are the foundation. This is based on a Houston Abbey in Norway in 1990, and based on that, the Houston protocol is devised, and it's a structured framework to do an OHCA care. And the Houston data elements. What are the Houston data elements? What is the system component? What is the dispatch component, patient component, process component, and outcomes? Like, for example, if we take translate it to our Hyderabad or Telangana, what is the population served by EMI or emergency system in our state or place? And after having a cardiac arrest, whom did the patient's bystander contact? Okay, next, process factors, patient factors. What are the clinical factors of the patient? And process factors. What is the process factors? Whether CPR was done, whether AED was used. Process factors, two important things are very important in attainment of or increasing survival. One is the zero flow interval. What is the zero flow interval? From the time of cardiac arrest to performance of CPR, or the first chest compression, is the zero flow interval. From the time of doing the chest compression, first chest compression, or starting CPR to attainment of ROSC or return of spontaneous circulation will impact the survival. So ultimately, return of spontaneous circulation at the site of the subject's place will only impact the survival. Okay, why this is important? ROSC. You must be seeing so many things. When someone, particularly a VIP, has a cardiac arrest, a film actor or a politician or someone, the next moment you see in the news, the only time when you see the media reporting this OHCA and giving importance, suddenly a media person calls me, sir, you have been doing CPR, please tell how to do CPR. Okay, I am very sorry. When other times when I call the other people and tell them that we need to improve conduct more and more CPR programs, none of them bother about improving the chain of survival concept in the state. Okay, the next thing is when someone has a cardiac arrest, VIP or a politician, whatever it is, the next thing is they take an interview from an interventional cardiologist or someone in the metro cities and say that ECMO plays a great role. If there is no return of spontaneous circulation, the earlier return of spontaneous circulation, ECMO, mechanical CPR, whatever it is, none of them work. That should be the take-home message. Otherwise, when someone has a cardiac arrest and they go to a hospital or corporate hospital tomorrow, the layperson, the common man will ask us, sir, why are you not doing ECMO for my patient and surviving the patient? You know what is the status of the patient? The certification will be broadened. That's it. Last more than 40 years when I am a medical student to a postgraduate to DM cardiology, till now, the only majority of the times in our country we hear the certification of death is cardiorespiratory arrest, no cause is written. Okay, now the message is because the topic is improving survival from OHCA in Telangana, certification of death should be proper. Okay, we have the administrators here. I think madam is not here. We have the educational administration, DME madam here. Now, there should be a need to now improve the certification of death in our systems, hospitals, both private hospitals and government hospitals. Okay, now where should I get it? When I started my research in 2017 December, I called the entire administration of Warangal, medical associations, IMA, doctors, both private and government. I want to do a study on out of hospital cardiac arrest. I need help from getting the data. Okay. When I contacted, they told me that only the municipal health department will give me. When I contacted the municipal commissioner, he told they don't have time to give me the data. Then I had to I was forced given the Right to Information Act to get the data. To get that. Now, you hear Statistics Department, the government of India will give data on cardiovascular disease. How can I rely on data given by the government of India when the certification by the municipal health department itself is wrong? No, when they go to the municipal health department, the data is from the local hospitals. Now, how to know whether the data is really correct or not? Okay, what I have done is, in 2018, January to December, I called all the patients' attendants and then inquired telephonically. That is the first registry on out of hospital cardiac arrest in India, regional registry as per international guidelines, that is the Epstein template. Okay, the first registry, one of the first in the world is CARE's registry, cardiac arrest registry to enhance survival. Actually, I contacted the principal administrator, investigator of CARE's registry, and I took his guideline along with Dr. Srinivas sir and University of Illinois staff. These are the three studies. So, because the study is focused on, my topic is focused on Telangana. First study is epidemiology of out of hospital cardiac arrest. 814 subjects of cardiac arrest brought to local MGM hospital. I took an ethics committee approval. I took a approval from the government of Telangana also. I gave a letter to the government of Telangana health secretary, the chief minister, and then the ethics local superintendent has given me the permission. We did it, and details of it you can find in the literature. Fortunately, this became the first registry and one of the in the country and one of the few in the world, apart in the particularly in a low resource setting. The other thing is the Warangal area out of hospital cardiac registry. This study, when I went it for a peer review in the Heart Journal, all the peer reviewers, which is a blinded one, they told me your data is incomplete. How can you publish this data? And fortunately, that's the problem. Data collection in this registry is the most important thing. And Elsevier, this got the fairest data award by the Elsevier for being the best data set of that year in 2020. The other thing is, we did the other study was the media reports from out of hospital cardiac arrest. That is the last 20 years, Hindu, Indian Express, Times of India. Search a word cardiac arrest. Then we separated in-hospital and out-of-hospital cardiac arrest. All the OHCA data, this is the second study in the world actually. The first media reports out-of-hospital cardiac arrest study is from UK, and the second in the medical literature in the world, media reports. Now, again the peer reviewer told, how can you rely on the media reports? See, if you take anything good from a media report also, that's very important. So media health literacy is the most important thing. Media plays an important role in creating interest among the public. See, if I can reach to my patients, it's only in my consultation chamber or my patients, but media has a great role. This study proved the role of media in highlighting cardiac arrest. The third study is an observational study of adult out of hospital cardiac clinic. Last 20 years, 25 years of my practice, the first number of patients, see, you must be surprised, and probably it's not uncommon that even in your clinics also as clinicians, you encounter subjects of cardiac arrest. A walk-in patient suddenly collapsing in your clinic. Okay, now as a cardiologist, being a high volume clinic with cardiovascular disease, the first patient came alone to my clinic. And he came alone, that was evening 4 o'clock, I was in my home, and I attended immediately because it was attached to my house, and he had a cardiac arrest. Fortunately, he revived in 2001 and he survived until 2020. He had an acute MI, severe LV dysfunction, on medical management only. He could not afford interventions because he was poor. Okay, this is the study. All such cases during the last 25 years until 2023, I collected, and we submitted a paper. Of them, 49, this may be a very small sample size, but of them, 20% are surviving. 15 are surviving, 11 of them are in regular follow-up, and they can find the results in the study. So this is the chain of survival as Dr. Vemuru Muthu sir has enumerated. one important thing in India in particular and our state in particular is recognition of cardiac arrest. Community awareness is very important. One study from Australia has proven that creating community awareness has increased the survival of OHCA subjects. Now, this is one of the book which we have written to increase community awareness. Maybe you and I conducting World Heart Day, No Tobacco Day, all these World Hypertension Day, Diabetes Day are not just a single day events, but their message, that message should continue throughout so that we increase the awareness on cardiovascular disease in our community. And Warangal is a place where I am more attached, and I face a lot of mutual admiration with many of my patients and politicians and the administrators and local people. Two important people is, you can see Sri Kaloji Narayana, who attended the World Art Day in 2001, and Sri Jaishankar sir, who is known to me from childhood. He released the book on the Know Your Heart, Meeru Mi Gunde, in 2008 World Heart Day in my alma mater, Kakatiya Medical College. These are some of the events. From 2001, what all events? Now, why I am highlighting is, all this is part of the journey which I have been doing for the last 20 years in improving survival rate in my patients and also out of hospital cardiac arrest in particular. Okay, you might ask why. Whether it is you or I, if any patient or person coming to our clinic, if we evaluate him that this person should not have an in-hospital cardiac arrest or this person should not have an out-of-hospital cardiac arrest, the message is clear and our work will be perfect in improving the survival rate of cardiac arrest. Okay? Now, for all the events which I have done for last 20 years, World Heart Day, health education and awareness in rural Telangana, the community programs which I have done in Vardhanapet, Retu Nagaram, Jangam, Parkal, Mehbubad, all these, mind you, are rural areas, and at all these programs, awareness programs and camps were conducted in government hospitals only, primary health centers, and I titled them as HEART program, Health, Education and Awareness in Rural Telangana. And fortunately, the World Heart Federation in 2013 and 2014 recognized it as a cost-effective, innovative community program in the developing world. And probably this is the only one from India out of the 12 which were recognized throughout the world actually. Bystander CPR. Of all the things in the chain of survival, early recognition and immediate performance of bystander CPR. Bystander CPR is one which is performed by a person who is not part of a organized system. Okay, even if a medical professional does a CPR, if it is not if he is not part of the EMS, then it becomes a bystander CPR. Okay, worldwide only 30% receive bystander CPR. In India, as per our study, it ranges from 2% to 25%. Now, is it really quality CPR or not? We will see. Okay, the number of people who are trained in CPR also worldwide it is 30 to 40%, but the awareness in India is less than 2%. There is what is called the bystander effect. Bystander effect is the person will not see what is the common situation in our country. When someone has a cardiac arrest, the person will be just standing. Everyone will be just standing there. Inertia. No one will be attempting anything. So that is the bystander effect, which is a common situation in OHCA. I suggest all of you to read this beautiful article, The Science Behind Hands. How CPR helps. One word for all the younger generation, young doctors here, how CPR helps. I was speaking to one of my teachers today. Once someone has a cardiac arrest, performing hands-only CPR immediately will see that the ATP depletion doesn't occur rapidly. It will see that. So, once someone has a cardiac, the ATP depletion doesn't occur, and until the ambulance arrives, the ATP depletion will not be there. So, it will be a shockable rhythm. So, shockable rhythm will be more when someone does a CPR immediately. So this is resuscitation. A 30-minute CPR education is the best one throughout that is the recommended one. Now, as sir has told, using the smartphone app and all that. So like we need to see that actually recently I was speaking to some of the National Institute of Technology faculty in Warangal to create an app about the improving the volunteer system in OHCA. NICE program. In 2015, along with Dr. Vemurumurthy sir, we initiated the National Initiative of CPR Education. In all the Indian languages, probably I have got pamphlets. Along with sir, we have written in English, Telugu, Urdu, Malayalam, Kannada, and recently I was speaking to one of my teachers. I think we need to create one in Sanskrit also, so that all the multilingual way of education should be there. And these are some of the programs which I have been doing from from 2009. I started basic CPR education in 2009. The press, see, it is not like doing CPR for one community on one World Heart Day and then stop. We should target in Warangal. I identified 100 places like school children, college students, press, railway station. We don't have an airport now. Okay, then we press, bank staff. Okay, so all these things, even the political officers, everyone should be trained. So I conducted in the press, court building.
Sir, sorry, sir. Next 2 minutes, you can
Sure.
wind up.
These are some of the programs which have targeted everyone, and sports meet also. Okay. And see, police commissioner and some of the things. So actually 2012 we did the largest one in the country, that is the on 12 or 4,500 people on a single day, along with from morning 5 o'clock to night 8 we trained them that attained the Limca records. This is the one which I initiated, that is the saving life. That is my logo, National CPR Challenge campaign, which I started. Thanks to World Art Federation, on 2023 I conducted the National CPR Challenge campaign over Zoom, 2022 post-COVID, where we reached, and it reached the World Art Federation website. And these are some of the people. In 2022, I requested the health minister to join in all the rural areas around Warangal, Jangam, Metur Nagaram, Parkal, Mehabad. I sent one representative volunteer from my clinic in all these places, around 15 places, Husnabad, Jangam, Parkal, Mehabad. We conducted training program to the local villages, and high quality CPR. One word about high quality CPR and what is chest compression fraction. The time during the cardiac arrest in which high quality chest compressions are given is chest compression fraction. The earlier only CPR, whether you are doing compression or not, was trained. But now we have to train every layman, including the medical profession, high quality CPR. So doing high quality CPR is very important. We have the QCPR mannequins by Lairdal. This works, and with a QCPR app, which is an Android and iOS, we can monitor the compressions. That will monitor the depth, the compression, and even the rate of compression. Okay.
Is that?
Okay. So
Thank-
ultimately, the role of cardiac cath lab, the post-resuscitation care, post-cardiac arrest care, neuroprognostication. Ultimately, if you want to know the theoretical aspect and practical aspects, 3 Cardiological Society of India 2021, 22, 23, I was given an opportunity to contribute a article on this. They are available, and can read the research articles also. Ultimately, to improve the survival rate of an out-of-hospital cardiac arrest, translating the Mahamrityunjaya mantra, where the news around Markandeya by Yama was saved by Lord Shiva. All of you are you may not be gods, but your actions are godly. And to translate Mahamrityunjaya mantra to the present day world, if you want to loosen the noose around the OHCA subject, in other words the Markandeya, and prevent premature death, okay, to premature death, the lay rescuer, the immediate bystander, EMS personnel, the AED application, post-cardiac arrest care, cardiologists, neurologists, anesthetists, intensivists, all of them in the form of Dashavataras in the present day Yuga are the ones who are going to save a subject of OHCA, and ultimately to improve the survival of OHCA. OHCA is a teamwork, and we need to improve the team performance in management of OHCA, and improve the survival rate of OHCA subjects, and to improve the survival rate in the state of Telangana in particular and India in general. Thank you so much.
Thank you. Thank you, Dr. Srinivas. This is a difficult area to collect data. Post-hospital, pre-hospital cardiac arrest is one of the difficult areas to collect the data. And it seems Dr. Srinivas did his best. And the data that he has collected hopefully will enhance the knowledge in the resuscitation field. So, thank you, Dr. Srinivas, again. And now there is a
One,
10 or 15.